Welcome to the Season 5 premiere of the BRG Nurse Executive Podcast. In today's episode, we'll discuss current industry trends and the need for health systems to employ integrated health solutions. My guest is Rich Bajner, Managing Director and leader of BRG's Healthcare Advisory Practice. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's Healthcare Performance Improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Rich, thank you so much for joining us today.
Pleasure to be here.
Before we get into our episode topic, can you introduce yourself to our listeners?
Based out of Chicago, where I've grown up and spent most of my life. Been in consulting now going on 20 years. I'm used to serving the healthcare industry in a variety of ways, but largely on the provider side and helping them rethink what the future of health is going to look like and what it means to how they deliver care, how they finance care, how they plan for their futures. So I've been fortunate to work with a number of amazing clients and a number of amazing systems. I've been in 49 states through the work. I'm still waiting on North Dakota, but I've been to the other 49 states. And excited to be here and talk a little bit about what the future may look like for those that may be listening.
You got me beat on the states. I'm only at 21 as of the date of this recording. So 49. And I think North Dakota actually has a thing that if it's your 50th state, when you get there, they've got some place that you're supposed to go to knock it off as being the last state. So interesting. That seems to be consistently a theme or a trend of that being people's last state.
There's not a ton of big healthcare systems there, so it should be so targeting should be relatively easy.
And your background before getting into consulting, you're not clinical.
My undergrad's in community health. I did quite a bit of advocacy work in healthcare space. So was part of Smoke Free Chicago, Smoke Free Illinois, and did a lot of advocacy work on mostly cancer-related issues, but some broader healthcare issues. So I was fortunate early in my career, really as a student, to travel the country doing advocacy work. It led me into following a passion that was healthcare. I went to University of Illinois where I studied community health and wasn't sure if I wanted to go the policy route or the education route, and learned a lot while there. Went to graduate school with a master's degree in healthcare administration. And it was there that I realized that healthcare is such a big percent of our overall economy that I wanted to be a force multiplier. And so I wanted to be on the forefront of issues that affected thousands, hundreds of thousands, even millions of people at the intersection between policy and business, and at the intersection of care delivery and how care was financed. So I always find myself in sort of gray spaces where I'm not the expert on one thing or two things. I like bringing experts together to tackle complex issues that can impact hundreds of thousands or millions of lives.
It's interesting that you're talking about those different elements and how they relate with one another. And it's making me think about, although the program doesn't exist anymore, there's a program that used to be around called the Robert Wood Johnson Nurse Executive Fellowship Program. And that was really geared around bringing together executives that were in the advocacy space, the policy space. That would be one domain. The second domain was practice, and the third was academia. And in understanding that the leaders in academia are properly preparing people for practice, and that practice is based on policy and how they all interrelate with one another. So interesting that you brought that up.
It always feels to me that a lot of times the academics that publish research that's critical, and oftentimes that research is on business issues in a healthcare environment, have never sat in the operational seat. And other times policy leaders read that academic work, but have never sat in the operational seat. And these seats almost, while they should overlap and coexist and learn from each other, the perspectives of many people are one position. And so I always wanted to be the person bringing joint perspective to solve problems. And I've been fortunate enough. A lot of my career I spend in between health insurance companies and provider networks. And I've been blessed to be able to do a lot of work where they're joint clients. So they say, Rich, here's our joint set of goals, but we're coming at it differently. Can you help interpret our goals and put together a future that we can buy into and work together better than we would in the past? So it's a neat space. It's a challenging space, but given some of the uncertainties in healthcare and the affordability challenges and the labor challenges that we have in really the near future, but certainly the longer term future, bringing together different perspectives, I think is what we're going to need to be able to do as a healthcare ecosystem, not just consultants serving the industry, but a broader ecosystem to solve some of these challenges.
That brings us to today's topic, and we've already started talking about it just by nature of our conversation. Our topic today is current industry trends and the need for integrated health solutions in the new emerging market that's going on right now. So as we kick off 2026, what really do you see as the biggest barriers that exist in healthcare as it relates to healthcare delivery? And how is BRG positioning itself to help providers generate that solution?
It's important to look back on a couple of themes that are almost hard to not accept as truths. Certain themes, a lot of the healthcare environment, you can debate certain types of facts or certain types of predictions, but there's some things that I think are just truths. You go back 30 years ago, 1990, healthcare was the largest employer in 0 states. If you add up all the healthcare jobs in a state, it was the largest employer in 0 states. As of the last data that I looked at a couple of years ago, maybe 2020, 2021, 2022, even pre-COVID, and healthcare has continued to grow since COVID, but healthcare is the largest employer in 44 states. So the role of healthcare in policy discussions at the federal level, the state level, the local levels has increased as it's become really a driver of local economies. So as we think about what the future of healthcare is and how BRG is trying to serve our clients, I think it has to start from a quality challenge. How are we making sure that healthcare is delivering the best quality to the communities that are reliant on it? If you look over the last 5 or 7 years, life expectancy in our country has actually gone down 3, 4, 5 of the last 7 years, which is the first time that's happened, I think, since World War II. And so I start with some aggregate stats like life expectancy, but not just comparing ourselves to others, just comparing ourselves to ourselves and the fact that it's gone down. So there's some major drivers of that we need to uncover and seek solutions for. At the same time, the affordability crisis that many, especially right now with open enrollment upon us, are feeling, and the dramatically higher premiums that employers are being charged and are being passed to employees are significant barriers to being able to access the care that many need. Lots of major challenges for us to be thinking about before we even start to talk about what's changing in terms of the role of AI or labor shortages or any number of issues that executives at any type of company in the healthcare market facing.
You talked earlier about bringing partners together and really looking at things from different viewpoint, and you threading that needle between the two of going, what is a true north? Can you talk a little bit more about that and provide some examples of that?
Yeah, I think there's 2 or 3 easy trends to pull apart and have good discussion on. So at the intersection of the financing of care and the delivery of care is how health insurers and health systems come together to essentially set contracts that create programs that providers are implementing that hopefully improve the quality of care, but it also sets together context and contracts for how healthcare is delivered. Over the last 15 years, there's been a pretty sizable trend in providers seeking premium dollar or even looking to start up insurance companies or partner with insurance companies differently as it's trying to find new revenue streams and new ways to drive more affordable healthcare for communities. And at the same time, insurance companies are trying to find new ways to implement programs to get nearer to providers, and some have even begun to purchase providers. What we're seeing, though, is as health systems are getting into non-core capabilities, the health plans that they're starting up are struggling. They're not creating scale. They're not creating the impact that they want. And similarly, the headwinds that are challenging our insurance companies are resulting in them in backing off of some of their assets, like you saw Aetna buying One Medical or buying provider assets and primary care groups, not working out for them. So I feel like right now we're seeing a return back to core businesses, which is forcing both of them to think about how they work together differently as they've meandered into each other's spaces and haven't been successful. Turns out it's harder to run an insurance company than providers thought. It's harder to run a health system than insurers thought. And so how they work together, I think, is a pretty big topic of conversation over the next few years.
Yeah, it's just thinking about the business cycle of expand versus contract. Going back to core business really is more of a contraction mode, if you will, while healthcare yet is in and of itself expanding. If I'm a chief nurse right now and I'm thinking about this and I'm looking and I'm going, okay, we heard Jeff Lieback talking earlier in 2025 about managed care contracts and the importance of whoever the contract guy is within a hospital or a health system to meet with them and understand how are we as a health system incentivized? What type of outcomes are our payers looking for so that we can gear ourselves that way? What else are other avenues of intersections that you see over the next few years of we're regressing to our core business, but yet we need to be reaching out and partnering in this new emerging world to be successful?
There's a really important role for clinical leaders that is, I don't know if it's returning or emerging or slightly changing, but I think the fact is most health systems are putting clinical leadership into corporate leadership and looking for clinical leaders to have a larger voice and a new voice in setting the direction that health systems or provider groups are taking. And I think that's an important trend, not to be understated. As care is shifting and as the population continues to age, the demand for healthcare is only going to grow. The challenge of affording that increased level of care is best understood and best solved by frontline clinicians that know those patients better than anybody else. So what I like to think about is AI has been given a big platform opportunity to improve what we know about the population we're caring for. How can we identify the sickest population, part of the population quicker? How can we predict who the future of the population, who's going to have different needs in the care delivery system? The underlying algorithms for that are clinical based, and the voice of the clinicians in identifying the role of AI in helping take care of these populations is going to be bigger. And the role of that voice, I think, is increasing in health systems across the country. Certainly the rise of new care models, whether it be telehealth type models or even virtual care models that are providing care to patients, not just in the acute care setting, but in a virtual setting or in their home setting I think we're on the early wave of that trend growing. And I think over the next 5 to 10 years, we'll see really an explosion of care into alternate sites of care. If over the next couple of years, I think many of the listeners may know, Medicare has changed its payment policy on inpatient-only DRGs. So care provided and forced into the inpatient setting because that's the only place it'll be reimbursed by Medicare. That inpatient-only list is going away. And by going away, Medicare, the largest insurance company in the country, is allowing that care to now be served in outpatient ambulatory settings, which should create a whole new demand for care in ambulatory settings, which I anticipate creating new business opportunities for care to be provided in ambulatory settings, and therefore new jobs for many of our frontline staff that have traditionally provided care to that population in that acute care setting.
There's more jobs that are going to be in the ambulatory setting. Some people will need to shift or may want to shift from an inpatient setting to an ambulatory setting. But as you mentioned earlier, we've got an aging population. We're getting older. So is the volume there to backfill in the hospital, or do you see overall hospital census going down as a result of this?
One of the stats I've loved to watch over the last 15, 20 years is inpatient utilization rates have gradually gone down by about 1% per year for more than a decade, almost 2 decades. It's been very consistent. So my first question and the first thought process is there going to be an accelerating decline on inpatient utilization on a per capita basis? I'm not sure of that. We've had the invention and the go-to-market of many drugs that have changed care patterns for certain diseases, especially cardiac disease. You've seen the migration of care for oncology into outpatient settings. we're seeing we're probably a lot more movement of orthopedics to outpatient settings. So we've seen this sort of disease system by disease system migrate outpatient, but in aggregate, we're still only seeing a 1.25% reduction in inpatient use on a per capita basis per year. I anticipate that trend to continue, but to be offset by an aging population. So not only a growing population, an aging population. And so when you look at the use rates coming down, population getting older with higher care needs, I anticipate that the role of the acute care will still be in high demand, similar to it is today, maybe slightly down. But the types of patients they're going to be caring for are going to be quite a bit different. Sicker patients, probably more complex medical patients. We'll see more of those patients. So what will that mean? How will we take care of patients in the acute care setting? The coordination between units, between nursing care and physicians, between nursing care and ancillary services, radiology and imaging is going to need to be more coordinated because the patients that present in that setting are going to be sicker and have many comorbidities.
Well, it also means that we need to make sure that we're properly preparing our workforce to be able to care for those patients. I know that there's been a lot of conversation lately, both on our podcast series and in other avenues, talking about the concern of, are we properly preparing new grad nurses to be successful in the acute care setting, and hearing that they're going to be sicker with new emerging technologies, all the more reason we need to make sure that we're properly preparing them for success and for great patient outcomes.
As we're talking about the demand for healthcare continuing to be high in any near to moderate scenario of the future, the workforce, of course, of nursing continues to age. And I don't know the exact percentages, but last I saw was 1 in 4 nurses are likely to retire over the next, 5 years by 2030 or so. So the demand on the nursing profession is going to force business model changes. I know there's so much that nurses do every day that can't just be automated and turned into an AI scribe, but I think there's going to be business models that are going to test regulatory rules around patient-nurse ratios or any other care delivery regulations. But it'll be an exciting future for those that opt into the nursing profession, certainly rewarding, but there'll be challenges and demands that will continue to be placed on a profession that is already a tired profession that has a lot of challenges, a lot of demands on it. I think we as an industry, it's a cohort of people that we certainly need to rethink how work is delivered.
Yeah, and it's not a secret. There's not a shortage of nurses. There's a shortage of nurses that are willing to still work in the profession. And that's the differentiating, I think, statistic. The question is, are they gone for good, or are they willing to come back? And if they're willing to come back, what does that look like of coming back to the bedside or coming back to patient care in some sort of capacity? And if it's a different capacity where they're not in direct patient care, then who is providing that direct patient care at the bedside?
As jobs are changing, certainly we need as many smart people taking care of our population, but also engaging in some of these more policy-oriented discussions around future regulation, future policy. And I think the nursing profession has a voice to be spoken for, and there'll be increased opportunities, hopefully, for that voice to be heard.
Any closing thoughts as we wrap up this episode?
I am excited about the future. There's a lot of people that can be down on the future of healthcare in our country. Through COVID, we proved that we can accelerate innovation if given the right environment. And hopefully the work that we can do, certainly at BRG, but more broadly speaking in healthcare, innovation will continue to accelerate and will not just be medical innovation, but business model innovation. And I look forward to hearing from any of the listeners with ideas that they have around some of the most innovative opportunities we have to solve the challenges ahead of us.
Current industry trends and the need for integrated health solutions has been our episode topic. Rich Bajner, Managing Director at BRG, thank you so much for your time today, and Happy New Year.
Happy New Year. Thanks for doing this.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.